for you. And because we have a lot of information to cover, rather than do introductions in person, I'm just going to ask if everyone could introduce themselves in the chat. Just put in your name and the name of the clinic or organization that you were with today. So then this way we can go ahead and get started. And also, I see some of you may be new to attending our ECHO series. And so I'd like to introduce myself. I'm Mary Ellen Kahn. I'm with Cancer Prevention and Control here at the WVU Cancer Institute. And if you are wanting to apply for CME or nursing credits, and if you didn't already put that information in your pre-registration, then also in the chat, if you could just put your name as well as your license number, so we can get that added for you. Okay, so what we will do at this time, we'll go ahead and get started. For those of you who are new to ECHO, our basic structure is that we do have presentations by subject matter experts, and that is followed by a case presentation. So we do ask you that as you are participating today, if you feel comfortable, please turn your camera on. And also please have yourself muted until we get to the question and answer portion of our meeting today. So what I would like to do at this time is I am going to turn it over to our presenters. They are Carly Likar, Amanda Moran, and Samantha Hall. I will let each of them introduce themselves as it becomes time for them to do their presentation. And so at this point, I'll ask if we could turn it over. Carly, I believe that we are starting with your presentation first.
Okay, great. Can you guys hear me?
Yes.
Okay, wonderful. So I will just go ahead and share my screen now, if that's okay.
Sounds good.
All right, perfect. So get this up. All right, can you see my slides? Okay, so today we are going to talk about various things in regards to the genetic world. I'm Carly Likar. I'm one of the PAs. I actually work in the Department of Surgery, specifically surgical oncology. I do genetic testing for a variety of different things, including Lynch syndrome, which we're going to talk to you about today, particularly my portion of it. But we also do genetic testing now for a variety of other cancers too. You know, from a GI standpoint is kind of what I focus on. So that would be pancreatic cancer and stomach cancer and so on and so forth. So I'm going to kick us off here and start with Lynch syndrome. We tried to, me and Sam and Amanda, we tried to pick disease states that people would see kind of on a routine basis, things that are very common. You know, as common as this can be, of course. But so we figured Lynch syndrome would be a hot topic there. So Lynch syndrome is known as hereditary non-polyposis colorectal cancer syndrome. Very important distinction. You know, we all know that majority of colon and rectal cancers form out of polyps. So you may be thinking, why is this called non-polyposis? This is an important distinction because it is different from the polyposis hereditary syndromes that we see with colon and rectal cancer, where they blanket. There's innumerable, oftentimes as they're described, polyps that blanket the entire colon. So important distinction there in its name, but hereditary non-polyposis colorectal cancer syndrome, otherwise known as Lynch syndrome. So discussion points from my standpoint, basics of Lynch syndrome, the genes that encompass Lynch syndrome, universal screening that we can do, testing criteria, and management. So Lynch syndrome in and of itself, it's the most common hereditary form of colon and rectal cancer. It accounts for about 2 to 4% of all colon cases, colorectal cases of cancer, and then 2.5% of all endometrial cases as well. Lifetime risks, when somebody has Lynch syndrome, they can have up to an 80% risk of developing colon and rectal cancer. and up to a 60% risk of developing endometrial cancer. So depending on the variant or the mutation that they have, they could have a very high risk of these cancers, of course, above the average population risk. Lynch syndrome is autosomal dominant, meaning that it's inherited in a 50-50 risk pattern. So each family member, of course, has a 50-50 chance of also having Lynch syndrome. You know, we have patients that come in that say, oh, I have 2 children. That means one will have Lynch syndrome, one won't have Lynch syndrome. No, it's a specific 50-50 risk for each family member. But not only does it increase the risk of colon and rectal cancer and endometrial cancer, the 2 primary cancers that we see, but also this list of other cancers as well. Certainly not as high of risk as the colon and the rectal and endometrial, but can increase the risk of gastric and ovarian, small bowel, everything listed there too. So these are actually, I say the 5 genes, but really EpCAM is just a downstream mutation that we can see with some of these other ones. So MLH1, MSH2, MSH6, and PMS2 are 4 mismatch repair genes. So the way I like to describe it to patients is if you think back to high school biology, when all the base pairs match up, when there is an error, these come in and they fix that error. But when you have one bad copy, as you can see here, or the non-functional allele, that does put a patient at risk of developing those cancers. So this is just basic genetics. When we see these mutations and things, we have one good copy or functional allele and one bad copy or a non-functional allele. And risk occurs when the mutation is acquired in the functional allele. So they already have that mutation, and then that it's like the 2-hit factor, I guess you can say. Rarely we can see that somebody has these changes, so a mutation or a loss of both alleles in the tumor itself. So that does not mean that they have Lynch syndrome, because it's not in all of their DNA in their body. It is specifically in the colon or rectal tumor or the endometrial tumor, whatever the tumor is. And we'll get to that here in a second. So universal screening, how do we find patients that may be at an increased risk of Lynch syndrome? Because not everybody that walks through the door with colon or rectal cancer, of course, has Lynch syndrome. So really taking a good history, personal and family history, of course, meeting certain clinical criteria, which we'll get to here in a second. Somatic testing on the tumor. So when you hear about genetic testing, there's somatic testing, meaning we test the tumor itself, and that's the cancer's genes, as well as the germline, which is the patient's DNA. So every cell in their body has this change, which then in turn leads to these increased risks. Here at WVU Medicine, we do immunohistochemistry, or IHC. It's a type of tumor testing, and I'll show you an example of that here on the next slide. That is a great avenue for us to really tease out who could be at an increased risk of Lynch syndrome. So we test every colon and rectal cancer here at WVU Medicine for that. And then also microsatellite instability testing is another way that we can do that. And actually a lot of our medical oncologists use this microsatellite instability to help guide treatments as well. The problem with these somatic tests is there is a false negative rate of about 5 to 10%. So we can miss patients that actually do have a genetic syndrome, but on their pathology from their biopsy, it looks normal. So if any abnormalities are found on either test, it should be followed up with germline genetic testing. So this is primary example. So this patient had a colonoscopy, and they were found to have a tumor in their colon or rectum. And we actually tested their tumor with immunohistochemistry for these mismatch repair proteins. So you can see here on the left side of the screen, it lists all of the Lynch syndrome genes, MLH1, MSH2, MSH6, and PMS2. And if you look on the right side of the screen, you'll see that 3 out of the 4 are intact. And so PMS2 there at the bottom, there is loss of nuclear expression. So with that being said, this makes us very suspicious that this patient has PMS2 related Lynch syndrome. Now, one caveat to that, just for something that we look for too, there is a lot, when you see a loss of MLH1 and PMS2 together, you should actually consider that it's actually a somatic change, so just there in the tumor. So we have to do additional testing to determine if somebody actually needs germline testing or if it's just in the tumor or not. So those patients don't always need germline testing if we can prove with these other tests, BRAF or hypermethylation, that it's related to that. But this is something primarily that we look at, and oftentimes we get referrals from our colorectal team, our GI team, because of these abnormalities seen on IHC. So testing criteria. So initially, if somebody, I always tell patients, if you would have been seeing me 10 years ago, we'd be having a very different conversation. So initially, testing was only offered to patients who met the following guidelines. So it's Amsterdam 2 criteria and revised Bethesda. The problem with that is approximately only 50% of families actually meet the Amsterdam 2 criteria and have Lynch syndrome. So we're missing a huge subset. In addition, only following these guidelines, not looking at anything else, may miss up to 68% of patients with Lynch syndrome. So these guidelines or these criteria have suboptimal sensitivity. So again, not the only things that we look at. But here's just a nice little schematic for that Amsterdam 2 criteria and the revised Bethesda. For Amsterdam 2 criteria, it goes off of the 3-2-1-0 rule. So it's an easy way to remember it. 3 or more relatives with histologically verified Lynch syndrome associated cancer. Now they do have to be, in first degree relatives of each other, so in succession. Cancer involves at least 2 generations, so along that same tract, or 1 or more cancers diagnosed before the age of 50. And then the 0 rule is that they do not have any polyps, so they don't have a polyposis syndrome, like I stated earlier. The revised Bethesda criteria, I won't go over all of these. You can take a peek at these later. But again, of course, people who are diagnosed before age 50, so we know a lot of these cancers happen, at younger ages. You develop more than one type of tumor. They have abnormalities on their pathology, so these lymphocytic reactions, mucinous or signet ring cell differentiation, all should be kind of making a genetic counselor or an APP or whoever does genetic testing think about, could this actually be Lynch syndrome? But the NCCN is something that we all essentially follow, and Sam and Amanda will probably reference this as well. So this is their criteria. It's very, very similar to the Amsterdam 2 criteria and the revised Bethesda. There's also, you can see kind of in the third bullet point down, there are actually models, so calculators we can type patients' information into, age of diagnosis, family history, those types of things. And if they're above a certain percentage risk, they recommend testing in those patients too. But really what I want to direct you guys to here at the bottom, I highlighted it, is that a direct referral for germline testing to rule out Lynch syndrome may be preferred in these certain subsets of patients. But now we're really leaning towards, for any patient diagnosed with colon and rectal cancer over the age of 50, they're really recommending that we do germline testing in everybody. And so this is up and coming. It's not a definitive recommendation. And, they always get away with that wording in medicine of consider. So this is something that we are leaning towards, and I think probably in the next few years we will see that change of that every colon and rectal patient should undergo genetic testing. So management. So again, risk varies slightly depending on which pathogenic variant a Lynch syndrome patient has. So again, do they have MSH2 or MSH6 or PMS2? For MSH6 and PMS2, their risks are a little bit lower. So we start colonoscopies at a later age, for example. So again, not all risks are the same across the board. But management is essentially the same. So we follow those NCCN guidelines, which I'll show you an example here in a second. Patients should be managed at a multidisciplinary level. So it involves many, many different providers across the board. PCPs for routine maintenance and screening, GI, of course, OBGYN, neurology, urology, and high-risk teams. So we each here in our programs, we run high-risk clinics where we see some of these patients back on a yearly basis to guide their management and screenings and things like that. And so that can be done through genetics or just oncology itself. So this is just an example of MLH1. It is the highest risk variant under Lynch syndrome umbrella. So you can kind of see here running down the list, the second column there from the left, cumulative risk for diagnosis through age 80. So for instance, colorectal cancer, if a patient has an MLH1 mutation, their risk of developing colon and rectal cancer by 80 is up to 61%. That is a stark contrast to the general population, which has about a 4% risk of developing colon and rectal cancer. So of course, these patients, their management should not be the same as the general population. So again, endometrial cancer up to a 54% risk. And you can kind of see as we move down that list, the risk is not as high for some of these others, but that doesn't mean that those patients are not at that risk. Every family, these mutations get expressed differently. So I've had Lynch syndrome families that have all endometrial and ovarian cancer and not a stitch of colon and rectal cancer. Rare, but it does indeed happen, and I have seen it. So, following NCCN guidelines for somebody who has MLH1, for instance, starting high quality colonoscopies at 20 to 25 or 2 to 5 years prior to the earliest colon cancer in the family if diagnosed before age 25, and repeating every 1 to 2 years. So definitely not the recommendation of, starting at 50 and repeating every 5 to 10 years, depending on findings. This is definitely a higher rate, a higher frequency of colonoscopies, and a lot more involved than just our standardized screening. Some patients, for surgical matters, it also determines what surgery we offer them. Sometimes we take out their entire colon and rectum in Lynch syndrome if they already have a cancer, of course, to prevent a subsequent cancer later on. But that's a big deal. If we tell our patients we need to take out your entire colon and rectum, they don't take that lightly. So, it is a really big discussion that, I turn over to the experts in our colon and rectal surgery teams and whatnot. So as we move forward here, it kind of goes into other recommendations, for endometrial and ovarian cancers. They talk about considering, so there's that word again, doing a prophylactic or risk reducing hysterectomy, a bilateral salpingo oophorectomy. They talk about it may reduce the incidence, but it has not been shown to reduce the mortality. So we do catch them more, but it goes into question, how many deaths do we actually prevent with that, unfortunately. So, but I always put in that referral, especially if a woman is done having children, to kind of go to gynecology, oncology, and talk about, going forward with these operations. From renal, pelvis, ureter, bladder standpoint, considering doing a urinalysis once a year. That's something I usually turn over to the PCP starting at age 30 to 35 years of age. Oftentimes that can be incorporated in the annual physical that most patients should be doing. For gastric small bowel cancers, upper GI surveillance, so upper scope starting at 30 to 40 years of age and repeating every 2 to 4 years. What's nice is you can try to do that in conjunction with colonoscopy. And so they undergo one procedure, rather than 2 separate ones, of course. And of course, they don't need it as frequently as the colonoscopies. And just so on and so forth, pancreatic cancer. Pancreatic screening is a very, very hot topic in the genetics world. It's not as clear cut as some of these other recommendations. So in Lynch syndrome particularly, we only screen patients for pancreatic cancer if they have a family history of it, particularly in a first or second degree relative thought to be on the same side of the family that the mutation comes from. The next 2, prostate, breast cancers. This is up and coming information too. We think that there could be an increased risk of these cancers, but really, as for recommendations past the general screenings, there's not much data there. Brain cancers, just watching for neurologic symptoms, skin manifestations, seeing a dermatologist every 1 to 2 years, and then reproductive options. I won't go into too much of this, but there are reproductive options for patients that are worried, they haven't had children yet, they want to seek fertility, so there are options there for that too. So real quick, this is basic information. I know autosomal dominant inheritance, all at-risk family members should be notified if somebody tests positive for Lynch syndrome and offer testing. With syndrome, there's no known pediatric cancer risks. So testing is recommended at age 18. Now that does change. So earlier testing could be recommended depending on family history. So I have seen Lynch syndrome as early as 18. In those patients, sometimes we do start a little bit sooner with those screenings because of that family history. In those circumstances, I do refer to pediatric genetics for those family members, just because it's a very tricky subject. There's a lot of ethical dilemmas when you think about that. So those are my references, of course, and that's it for me. So I'll turn it over to Sam.
Thank you, Carly. So I'm Samantha Hall. I'm one of the nurse practitioners here at the WVU Cancer Institute. I work with medical oncology, and I specifically see patients who have breast cancer. Carly, can you move my slide?
Hey, sorry, do you want me to move it, or do you want me to share, or do you want to share it?
You can just move it. It's okay.
Okay, sounds good.
So we're going to be talking about BRCA1 and 2, switch gears a little bit to breast cancer as opposed to primarily colorectal. So 1 in 400 people are actually walking around with either a BRCA1 or 2 mutation. BRCA1 and 2 both function as tumor suppressor genes. So when there's a mutation in one, we're no longer able to suppress tumors like we normally would. Carly referred earlier to what we call an autosomal dominant mutation, meaning there's a 50-50 chance that it's passed along to the next generation. These don't skip generations. BRCA1 and 2 are the same. They are also autosomal dominant. So if mom has it, 50-50 chance each of the children got it. These are the testing criteria per NCCN guidelines. I pulled this off of the most current version of NCCN. So this gets a little bit less stringent for breast cancer every year. Now, if somebody is diagnosed with breast cancer, they would automatically qualify per NCCN guidelines if they're diagnosed under the age of 50, if they're diagnosed at any age with what we call a triple negative breast cancer, if they have multiple primaries, if it's a male, if they have an Ashkenazi Jewish ancestry, because those patients are at a higher risk for developing one of the founder mutations for BRCA, or if they're above 50 and they have a male breast cancer relative, if they have a family history of ovarian cancer, pancreatic cancer, metastatic prostate cancer, somebody else in the family with breast cancer at a young age. Or even if people don't have a history of breast cancer, they can still qualify for genetic testing if they also have a family history, again, of ovarian, of pancreatic, of metastatic prostate, of male breast cancer, or somebody diagnosed kind of young. Here at the Cancer Center, we actually do offer genetic testing to all of our newly diagnosed breast cancer patients. There's a caveat that your insurance may or may not pay for it if you don't technically meet these criteria or whatever criteria the insurance sets forth. But testing is getting more affordable by the day, so that's really wonderful for patients. So let's say somebody does test positive. So we see them in clinic, we get a tube of blood. You can also send a saliva sample, but I usually prefer blood. It's a little less messy actually for the patient. So we send a tube of blood, we usually get results back in 2 to 3 weeks. And let's say we find a BRCA1 or BRCA2 mutation. We quote women that there is up to a 90% lifetime risk for developing breast cancer, which is kind of an astronomical amount when you think about it. So then what do? We either screen them early and we screen them often. So we start at age 25 if we find it soon enough with breast MRIs. We do them annually until they hit age 30. And then we throw in mammograms. So then we start staggering them. So every 6 months, patients should have some kind of imaging. If you have a mammogram in January, come July, you're going to have a breast MRI, so on and so forth. The other alternative is a risk-reducing bilateral mastectomy. So some women do choose to undergo surgery to have essentially all or most of the breast tissue removed to prevent the risk of cancer or decrease it by 95 to 99%. And that surgery is not for everyone. It is certainly a major surgery, and some women want to think about it. Some women choose to never do it. So in that case, we just go back to their screening, their breast MRI, their mammogram every 6 months. There's also a risk of male breast cancer because I frequently hear, oh, I have the gene, but my son doesn't need to be tested. Absolutely not the case. There is an increased risk of male breast cancer. While we don't mammogram and breast MRI them, we do talk to them about doing their own exams, finding things on the chest wall, signs and symptoms. If they have nipple discharge or something like that, those are things that need to be worked up for male breast cancer. We also quote women a very high lifetime risk of ovarian cancer, which can be up to 60% depending on the mutation. So as we all know, there's not great screening tools for ovarian cancer. Otherwise, we do them for everyone. Transvaginal ultrasounds and CA-125, which is the ovarian cancer tumor marker, which is just a simple blood draw, can be done, but it's one of those things where, again, it says consider. It's a discussion that we have individualized with patients, especially if there would happen to be a strong family history of ovarian cancer or something. Those are things to talk about. But again, some women choose eventually to have a risk-reducing BSO. So we take out the tubes, we take out the ovaries. In BRCA1, we can even take out the uterus because there's a slight risk of uterine cancer with BRCA1 as well. But we also don't want to throw somebody into an early menopause at, say, 25. So we talk about it with BRCA1 patients, usually starting around 35, and then with BRCA2 patients, usually starting around age 40. There is a risk of pancreatic cancer with BRCA1 and BRCA2. It's up to a 10% lifetime risk. Carly touched a little on the screening for pancreatic cancer, and we kind of treat that the same with BRCA. So the studies are still ongoing, and if we're screening patients for pancreatic cancer, we prefer to do it on a clinical trial. But if somebody has a significant family history as well as a mutation that puts them at a higher risk, there are certain centers that will do things like MRI, MRCP, and or an endoscopic ultrasound, but that's something that you would refer them to an advanced endoscopist or a specialist for. There's a risk of prostate cancer associated with BRCA2. It's up to a 60% lifetime risk, so we do draw PSAs on men. And there's a slight increased risk of melanoma, both skin and eye melanoma with BRCA2. So we make sure patients have annual skin and eye exams. Carly, I think the next one is actually my case, your case. Good.
All right, so I don't know if we wanted to do Amanda's portion and then loop back around to the cases.
I think that would be the best, because normally we do hold case presentations towards the end. And also Andy had put a message in the chat that we are going to hold all questions until Amanda finishes her presentation. So if you have a question, you can wait until then, or feel free to go ahead and put it into the chat.
If it helps, my case presentations are also kind of built into my PowerPoint slides as well. So I don't know if it's easier just to continue one after the other or try to bring those back.
We can bring them back.
Amanda, did you want me to share your slides for you? I'm sorry. I'm sorry, you're muted. It's okay.
Yeah, could you please and run
Yeah.
them for me? I'm just doing this off my cell phone.
Oh, yes, gosh, yes. Give me just 1 second.
So much.
And while Andy is doing that, I'll also comment again about the CME and nursing credits that are being offered for today's session. If this is your first time attending one of our cancer echoes and you are wanting to request CME or nursing credits, in the chat, Andy did put, we do have a CME registration form that is specific to our Project Echo. So if you would please fill that out, you only have to fill that out one time. And then that way that helps the CME office in processing all the educational credits.
Thank you, Andy, very much. And I'll just kind of tell you when to move to the next slide. So I'm Amanda Moran, and I am the high-risk PA for Surgeon, specifically breast. So I do a majority of the managing of our high-risk ladies here in the breast program. And so while Sam talked to you specifically about BRCA mutations and Carly talked to you specifically about, hereditary GI syndromes, this presentation was a little snippet from the breast cancer conference that we did back in July. Beyond the genetic testing, management of patients with uninformed results, as well as respect to what we're looking for when we're doing this testing and the potential outcomes. Because when you get into the process of genetic testing, you really have to be prepared to handle all those different aspects. You can go ahead and change slides. So when you are seeing a patient and you're discussing genetic testing or evaluating the family history, you really have to come into this with a strategy. So what are you specifically looking for? What are you going to specifically test for? And then how are you going to manage those patients based off of those potential outcomes? So I always tell patients there's 4 potential outcomes with genetic testing. The first result is a positive result. The second result is a negative result. You have uninformative results due to variants of uncertain significance, or you can be a carrier status for a syndrome. Okay, now you can slide. So again, as Carly and Sam outlined, you are looking for specific things when it comes to hereditary cancer testing. So cancer that's happening before it should be happening, we call this atypical ages of onset. There's associated tumor spectrum. So not just a lot of cancer happening, but specific types of cancers happening in these close blood degree relatives. And then those patterns of transmission. So can you follow it through the generations? Go ahead and slide. The big thing that we're looking for too is, aside from those obvious family histories concerning for hereditary cancer syndromes, is that the evolution of genetic testing has made leaps and bounds over the past 10 years. So we are really moving towards population-based screening, which I also wanted to touch on as an adjunct with this. And so population-based screening is, you're evaluating a patient or they don't necessarily meet criteria, but it's just for information's sake. So we have the sophistication now to screen people's genes, see if they have a predisposition to developing certain cancers. And then the whole goal moving forward is, if you're able to identify that cause or that increased risk, then how do we modify the future medical management to reflect that? Population-based screening is we're seeing it more and more now. Genetic testing is now a competitive market. Costs are coming down. It's widely available. And the majority of patients can actually request this at a $250 pocket expense or less through most labs. And you can slide. So we always talk about multi-gene panel testing. So, at this point, genetic mutations cross-cover so many different malignancies. It's really inappropriate to just test a patient for BRCA1 and BRCA2 in most cases, or just test a patient for just those 4 Lynch syndrome genes. We have multiple genes that can predispose people to developing multiple cancers. And as Carly alluded to, not all family histories present is something that's kind of a cookie cutter for a specific syndrome. The process of genetic testing really is done in bulk. So remember, if you're going to genetic test the patient for a specific syndrome, if insurance approves that, but you don't do the panel testing up front, you may lose the ability to go back and do more. And so when it comes to the potential cost of testing, the efficiency, the out-of-pocket expense, you always want to do multi-gene panel testing up front. Slide. This is the other big part of genetic testing. So we talked about positive syndromes and the management of those syndromes with Carly and Sam, but what if those results are normal? And so the significant, or I should say, the majority of the time, you will have uninformative or normal testing results in these patients. So if you sat down and you told them that you've had a concern for hereditary cancer syndrome, you talked about all the potential outcomes of testing, all the potential for genetic mutations, all the things that you're going to do if those results are positive. What if those results are actually normal? So you have to be able to address why, how, and now how do you individualize that patient's care reflective of the family history, as well as the normal results that you've received. Go ahead and slide. So again, the care doesn't stop here. You have to discuss the limitations of testing. The problem with population-based screening, or probably what you see more often in clinic, or was what I see, is women are coming in with family histories of the disease, not necessarily they are affected with the disease. And so, there are limitations due to that autosomal autosomal dominant pattern of transmission, meaning that there's a 50-50 chance that they did or they didn't inherit those mutations. So if you are population-based screening, or if you are testing the, unaffected family members, there's a 50% chance that the family history is due to a hereditary cancer syndrome. They simply didn't inherit that. And if they didn't inherit that, they didn't inherit the risk. So you always want to talk to them about those limitations, as well as attempting to test the affected relatives for comparison of those results. Specifically, I work with a lot of breast. There are some other algorithms out there where if results are uninformative in your patient, as well as uninformative in the affected patients, you should fall back and do sporadic risk assessment models, which help you assess that individual's risk for developing the disease, as well as incorporate the family history of the disease, quantify that in the theoretical assessment, and then use that information to modify the future medical management. Again, the whole goal there is early detection and prevention of those cancers that they could be a risk for. And then, yeah, you can slide again. And then here are my case studies. So I don't know if we want to save those for last, or if you just want me to lead into these, and then we can add everybody else's on.
If we could go ahead and take pause for a moment and see if anyone has any questions for our presenters today. As I said, you can feel free to take yourself off mute to ask your question, or you can put it in the chat if you prefer. We'll give a moment to see if anyone has any questions. There is one question that I have that I'd like to ask of our panel today. For patients who do receive genetic testing and who would have positive results showing that they are at increased risk, in addition to some of the referrals that you make for ongoing testing, what about on the psychosocial side? Do patients have difficulty in dealing with the impact of knowing that they have increased risk?
That's a great question. I think some of my later slides after my case studies address that. Is one of the main points during genetic testing is counseling is the potential psychological and emotional aspects of genetic testing, especially in the setting of positive results, is oftentimes overlooked. And I would say that the majority of patients aren't counseled, or we don't do a well enough job at addressing that. So typically before I draw and send testing, I make sure to comment on, positive results are life-changing. It can be life-changing information. Uninformative results, or even just having the patient sit down and really acknowledging the family history and acknowledging the potential concerns there, can be emotionally difficult. So depending on the outcome of testing, especially it's hard for women who maybe have young children, and some of these genetic testings can be associated with childhood malignancies. Try to make sure that we utilize our resources within the cancer center, as far as supportive care, our psych-onc department, to have the resources that they need. But we try to prepare them up front for that potential.
Okay, thank you. Do either of our other panelists have any comments to that?
So I completely agree with Amanda. I think it's something that does need to be addressed during your pre-test counseling, especially if let's say we know somebody has a Lynch syndrome mutation, or we know somebody's family has a Lynch syndrome mutation and you're testing them for this. They need to be prepared that there's a real possibility that this does come back positive. But then beyond that, let's say they do come back positive, and you start talking to a woman who has a BRCA mutation about potentially removing her breasts. That adds a whole other layer onto the fact that, yes, it's a positive result, and yes, there's a risk for cancer, but now us doing something about that, or even just the anxiety associated with a mammogram and a breast MRI that you were not going to get until you were 40 and now you're 30. There's a whole lot of anxiety that can potentially go into these things. So they're all things that we need to learn to acknowledge as providers and try to sort of address upfront.
Okay, thank you.
We do have a question in the chat too.
Although I think, Carly, were you ready to make?
Oh,
a
I'm
comment?
sorry. Go ahead, Carly.
No, that's totally fine. I was just going to say that I definitely agree, obviously, with Amanda and Sam. And, I personally have had people come in and you really, I agree, doing the pre-test counseling is so important, because I've had people say, I didn't know that it involved all of this. I wasn't aware that it included, the potentials for these management strategies or surgeries or scans or, the frequency of all of this. I think another important point is with how easily accessible commercial genetic testing is too. Especially around Christmas, you see every other commercial is 23andMe or Color, and while those are mostly used for family and things like that, they do test for founder mutations, and I think Amanda and Sam have seen it too, where people come in with those results and they're nervous, but they don't really know what that means. And so you walk this fine line of commercial testing versus medical grade genetic testing, and how you can implement one with the other, and what that means moving forward. But yeah, that's a great point. The psychosocial side of it can be very, very damaging, especially when it gets to early menopause for women, for instance. They realize, yes, I want my ovaries out, I want my uterus out, I want everything taken, but they don't realize the implications of, if they're 40, what could that mean lifelong for them moving forward? And from a GI standpoint, if we take out the entire colon and rectum, what does that mean in terms of an ostomy or lifestyle modifications and things? So I think we try to do a very good job of pre-test counseling, but there's still loopholes of, no matter how much you explain it, until a patient gets that positive result, they don't really know what they would do in that circumstance. So that's a great point.
Thank you. And Andy, you said there was a question in the chat.
Yeah, Dr. Haggerty asks, if we have concerns for a patient, would we refer them for testing at the cancer center or genetics?
I think there is a genetics referral to the cancer center built into Epic. So if you, and somebody can correct me if I'm wrong, I think if you place a referral for genetic testing, an option comes up for genetics at MBRCC, and then you can select that option. Triage to the appropriate provider. So if it's, being referred to family history of colon, it would be likely scheduled with Carly versus breast or ovarian, myself or Sam.
Yeah, that's correct. There is an option that pops up that says genetics at MBRCC. There probably is another order in that just says general genetics, and that's probably for the pediatric genetics department, because they do that as well. But it's my understanding, I think that there's no one left in the department at the moment. So adult cancer genetics usually comes to us here at the Cancer Center.
Yep.
Okay, thank you. Any other questions? Okay, if there are no other questions for our panel, we'll go ahead and move on to the case presentation. And Amanda, since your slides were already up, we'll have you go first.
Great, thank you. So these are case presentations, of course, that focus on uninformative results. Sam will do case presentations for positive BRCA results, I'm sure. And so typically when I see women who are presenting for genetic counseling or testing due to family histories of the disease, my assessment and evaluation looks a lot like this. So we break down, of course, the patient, both maternal and paternal sides of the family, and then I assess that patient's individual sporadic risk factors. So you can see all the things highlighted in pink are things that I take into account when I'm quantifying not only their personal risk factors, but as well as the family history. And then there's their constructed pedigree, of course. Next slide. And then, of course, we did multi-gene panel testing for this individual, and those results were uninformative. And so because her results were uninformative, these are these sporadic risk assessment models. So there are multiple different sporadic risk assessment models that you can use. The important thing to know is you have to choose